Dr. Shreya Patel, presenting as pediatric massive B-cell non-Hodgkin's lymphoma, effective chemotherapy in a 13-year-old.
Good evening. My case is a rare case of pediatric orbital non-Hodgkin's lymphoma with significant response to chemotherapy. There was an 11-year-old girl who presented to us with protrusion of eyeball, downward displacement of eyeball. She also had a diminution of vision, watering and redness along with lid edema and cosmetic deformity since 2 months. On examination, there was 4 cm downward and outward proptosis with exposure keratopathy. The incisional biopsy was done and it came out to be lymphoblastic variety of non-Hodgkin's lymphoma, and the patient was referred to the oncologist. But because of negligence by parents, they were lost to follow-up, and they came back to us after a year. And 1 year later, the mass had significantly increased. There was facial disfigurement, loss of normal anatomy involving the left eye, periorbital region, and extending up to the malar area, bridge of nose, and projecting outwards. The surface was hard, irregular, with areas of ulceration, necrosis, crusting, and the margins were ill-defined and blending with the surrounding tissue. MRI was done, which came out to be a heterogeneous and the mass was also extending up to the frontal region, but there was no systemic metastasis. Other investigations were done that included bone marrow biopsy and cytogenetics. It came out to be AML-M2 also. So she had a systemic correlation with AML-M2 because the T821 was positive, also CD13, 33 and MPO were positive. The management was started by the oncologist with lymphoblastic induction protocol, vincristine, daunorubicin, cyclophosphamide and prednisolone. Later on, when it came out to be AML-M2 subtype, the patient was shifted to AML-specific chemotherapy that included daunorubicin plus cytarabine, and for consolidation phase, high-dose cytarabine was given. GCSF was also given for neutrophil recovery. During the chemotherapy, the patient suffered massive subhyaloid hemorrhage in the fellow eye, which led to diminution of vision in that eye. But at present, the patient has visual acuity of 660, pinhole 624, but she was not able to recover the original vision. She also had systemic side effects due to herpes and mucocutaneous blisters and herpetic stomatitis. But patient after chemotherapy, the orbital mass reduced significantly within 4 months. Visual prognosis remained poor and patient is clinically stable at present. Literature says that pediatric orbital non-Hodgkin lymphoma accounts for less than 1% of the non-Hodgkin lymphoma, and reported incidence of pediatric orbital lymphoma is only 0.12 per million per year. Unlike Burkitt's lymphoma, lymphoblastic variety is also specifically very rare, and large orbital masses more than 8 cm are exceptionally rare. It is usually linked to delayed diagnosis or aggressive disease. In present case, we came to know that the orbital non-Hodgkin lymphoma is rare but chemosensitive tumor. Large size was due to delayed follow-up and socio-economic barriers. Systemic evaluation is critical because it was able to find out the occult hematological malignancy, that is AML. Early diagnosis could have prevented visual loss in this case. AML with T821 has relatively favorable prognosis. Also, I would like to end with a short review of literature. Across pediatric primary orbital non-Hodgkin lymphoma, no cases with concurrent AML have been identified. Adult cases do exist, but pediatric coexistence is exceptionally rare, and this underscores the uniqueness of this case. Thank you.
Any questions? Anyone?